Good morning. I'd like to talk today about polygenic testing of embryos. This is the first in a series of videos I'm going to make on pre-implantation genetic testing. And I'm going to jump into the deep end and do the hardest one first, which is polygenic testing of embryos called PGT-P. The talk was prompted by an article that appeared just recently in Fertility and Sterility called The Polygenic Revolution and the Future of Embryo Testing. It's by three authors of high repute in terms of embryo genetics, but they acknowledge they're all the employees of and owners of stock in Herisite, which is a company that is specialising in polygenic prediction and other kinds of genetic testing. So my declaration is I have no interest in any PGT company, unfortunately. I'm just an embryologist and I'm presenting my view on the role of PGT in future IVF. As the authors pointed out, PGT-P is the end of a natural extension, if you like, natural end extension of all the genetic work done in IVF. The first major innovation was the advent of pre-implantation genetic testing for aneuploidy, PGT-A, which is a way to test embryos for chromosomal abnormalities or number of chromosomes, whether they have the right number or not, and identify such syndromes as Down syndrome and aneuploidy. But it's also highlighted that around about between 40 to 6% of all the embryos fail at this particular point. The next innovation was PGT-M, where they're testing for a specific monogenic disorder, that is one gene, which tests for monogenic conditions such as Tay-Sachs disease. So it's the same technique where you take a biopsy, usually at the trophectoderm of the blastocyst, a few number of cells, 5 to 8, and then the DNA is magnified many times, and then it's tested not for the number of chromosomes, but for the presence or absence of a particular gene. It's important to highlight the success of these two forms of embryo testing. PGT-M in particular has allowed parents to avoid transmitting both recessive single gene disorders, such as cystic fibrosis, and pathogenic variants with a dominant inheritance, such as those with the BRCA1 or BRCA2, which substantially increase the risk of breast and ovarian cancer. And I think we're just at the very forefront of using IVF to pursue this. In fact, the very first testing ever done of an embryo was for mental retardation that was linked to the X chromosome. And back in 1990, Alan Handyside and co-authors used the very first genetic probes looking at testing for the centromere of these chromosomes for whether it was an X and a Y chromosome. I think the Y was a red colour, the X was a yellow colour. So an embryo, a cell from an embryo, they're taken from day 2 or day 3 embryos. So a cell with 2 yellow dots, so it was female, and a red dot and a yellow dot indicate it was a male. The male embryos were discarded and the 2 yellow dot embryos were put back, and they confirmed that they were both females that were born identical twins without any condition of mental retardation or other particular extant diseases. But PGT-M, I'm just going to digress just slightly, because PGT-M has been going for several years now. In fact, I think I'll do a talk on it next month. But already there is an ethical basis from which to progress from PGT-M to PGT-P. So the monogenic one is pre-implantation genetic testing for monogenic diseases for adult onset conditions is ethically permissible for a range of conditions, including where the condition is serious and not safe, and then there is no safe, effective interventions that are available. The committee strongly recommends that a genetic counsellor experienced with PGT-M counsel patients considering such procedures. So this is one of the main things they pointed out, that right from the very outset, couples need to be counselled by a specialist genetic counsellor because of the complexity of what they're trying to do. Polygenic testing is orders of magnitude more complex. So you don't need to read this quickly. I'm not going to read the whole out. The key point is that they say, well, I probably will read the whole out, pre-implantation genetic testing for monogenic diseases for adult onset conditions is ethically justifiable. And so they're basically saying it's right to be able to select embryos that contain the healthy and non-healthy genetic variants. And even where there is less power of penetrance, that it's not really a direct thing, but a more family-orientated one, is still ethically acceptable as a matter of reproductive liberty. The clinicians and patients need to recognise that not a lot is known about the impacts of doing biopsies on embryos and genetic testing, and it's important that they all be exposed to it with the technology through a genetic counsellor. And if an IVF team is not comfortable transferring embryos that may result in offspring affected by a disease in question, they're not obligated to do so. Just because they make an embryo tested, the couple may still want that embryo transferred. The clinic should has a right to say, no, I don't want to be involved in that, but they should do that before the treatment starts. The other thing that PGT-M does is that then they're mainly treating people that are fertile but have a inheritable disease, so they're not infertile that IVF was first developed for. And if you look at the pregnancy rates from reported by this group in 2025 in the American Journal of Obstetrics and Gynecology, they looked at over 1,300 publications, which tells you a lot, and looking at 5,000 cycles and 5,000 transfers and 1,500 births. But they calculate that the clinical pregnancy birth rate was 34% and 20% per cycle, and 25 and 22% per embryo transfer. So that's probably in the same ballpark as IVF, maybe just a tad low. But money depends on the age of these couples coming through. And the other interesting thing, which I've included, once again, it's too many writing numbers on a page, but when you do PGT-M, as you do for PGT-P, you can at the same time test for aneuploidy, that is whether there are 46 chromosomes in the cell or more or less, that is if we lost or gained some chromosomes, and whether there's a mixture. And if you do the testing without, for the monogenic disease, without the aneuploid testing, pregnancy rates are quite high, but there is a substantial risk of miscarriage. If you do it without the testing, it's a little bit high, 32%, 31%. But if you do it with aneuploid testing, you do far fewer transfers, but the pregnancy rate is quite high. So if you have a monogenic disease like for breast cancer, and you come through and you have your embryos tested both for aneuploidy and for the monogenic disease, and the embryo that is normal, both euploid and not carrying the gene, the pregnancy rate per cycle and the life birth rate is 43% and 37%, which is on par, of course, for IVF. And I just want to raise another publication before I get back to the main one. This one was published in 2020, looking at polygenic disease risks, evaluating the concept of risk reduction. And they say that pre-implantation genetic testing for polygenic diseases represents a new tool in aid of embryo selection. Previous studies have demonstrated the ability to obtain the necessary genotypes of the embryo with accuracy equivalent to adults. That is, you test the embryo and test adults, and you have roughly the same diagnosis. In other words, if you test an embryo, you don't get a substantially poorer diagnosis. When applied to adult siblings with, say, type 1 diabetes, and you apply a genomic score risk or polygenic testing, you have potential to reduce the incidence of disease in the offspring by up to 50%. So there is substantial gains if a condition like diabetes is running strongly in a family. And the results demonstrate, which I'll show one graph a bit later on, demonstrate that a simultaneous relative risk reduction for all diseases tested in parallel, which includes diabetes, cancer, heart disease, and many more, you get a similar sort of risk reduction if you apply embryo selection. In other words, they think there is gain for the adults if you apply PGT-P to people with a known history of some genetic condition. Okay. But people have questioned whether, in fact, you should apply it, because it's a big quantum leap from doing IVF and just trying to get women pregnant or a couple have a child, to try and remove in a family line genetic conditions which are polygenic, that many genes contribute to it, and not knowing the outcome. It's a bit more towards gene selection. So there's a couple of points they wanted to address. I want to say they have a vested interest in promoting because they own the company. So they say The falling cost and rising accuracy of genetic sequencing has enabled the creation of large research resources, including national biobanks, that sequence hundreds of thousands of participants and link genomic data with traits of interest like height or disease diagnosis like diabetes and schizophrenia. With a large enough sample size, and it's growing all the time, and the right statistical technique, of which I gather there are many, data from biobanks allow experts to create a polygenic score. More importantly, for reproductive medicine, to the extent that polygenic scores can predict early outcomes, they can also be used to predict with varying degrees of certainty or uncertainty what traits or medical risk an embryo will develop if as an adult, but after it's been transferred. Polygenic scoring allows for a new kind of genetic test, PGT-P, which is an embryo selection based on polygenic disorders, and in such cases height, rather than morphology and the likelihood of pregnancy. Which leads us to the concept about PGT-P. And the authors make a note that most diseases are not caused by a single gene. They're polygenic, which means that multiple genetic variants, often hundreds or thousands, along with environmental factors, contribute to an overall probability of a disease. So like breast cancer, that a disease will emerge. While polygenic scorings cannot yet capture anywhere near the entire known heritability of most diseases or traits, they're getting better every year. So really the question is, at what point in time do you have confidence in the technology to apply it to IVF and future children? And maybe one of the concerns people have is that even though they say they're getting better, maybe they're not good enough to actually apply it clinically. And there's another argument people make, that some argue that polygenic scores should not be used to guide a patient's selection of which embryos transfer because they lack clinical utility. That is, you can't apply it because the polygenic scores are too disparate. In general, the gains in risk reduction for polygenic screening depend on factors that may include how many embryos a couple has to choose from, the family history of disease, and the luck of the genetic draw after a round of IVF. To conclude that PGT-P should not be offered simply because it has limited clinical utility for patients with very few embryos and no family history of the disease, they say is wrong. It's wrong for two reasons. The first is it undermines the presumption of favour of reproductive autonomy, the ability of parents to use medically useful information to guide their reproductive choices. Second, to discourage or restrict the use of PGT-P for all patients on the assumption that it has limited utility for some patients is to deprive those parents for whom it has great utility from using it to reduce the risk or otherwise influence the traits of the children they have. Think of breast cancer or bowel cancer and your views will immediately be drawn to the fact that it should be available. To deny couples having IVF the option to use, couples with the family history of breast cancer, to deny them the option to use IVF and choose an embryo that has a very low trait for breast cancer is infinitely better than falling pregnant and doing amniocentesis and then aborting the child. It's infinitely superior to that option, or to have a child knowing it's going to have a high risk of breast cancer and diabetes and continue to have it. Another question leads us portability and access. Here the problem stems from the fact that since the science of polygenic testing scores have been developed in Western country, polygenic scores are trained predominantly on people with European ancestry, which results in reduced predictive power in people of non-European ancestry. Similarly, while the genetic scores do not work identically for all groups, there can still be substantial benefits for parents to use PGT-P, especially if they have enough embryos, a strong family history of disease, or simply because they want to understand a bit more about their embryos before they elect which ones to transfer. Another argument they make is pleiopatry, which I hope I said that correct. And that's the definition, that is the production by a single gene of two or more apparently unrelinked effects. So the authors make a point that pleiopatry occurs where one or more genes produce multiple phenotypic effects, that is the effects on the adult, the phenotype. The worry is that if parents select against a condition like bipolar disorder or diabetes, they may have unknown negative consequences. The implication of PGT-P is that when parents select against one physical or mental disease, they usually end up selecting against others, since many disease traits positively correlate with one another. But that is not to say that pleiopatry is not irrelevant. And finally, it's got to do with access. There's a lot of words here, and I'll go through them quickly, but it's important. Finally, the author make the point, the fertility doctors sometimes object to the use of PGT-P because it may result in reducing the chance of achieving a pregnancy by deselecting embryos with the highest chance of producing a viable pregnancy. That is, you may choose an embryo which is less likely to form pregnant but will meet your genetic goals. This is a legitimate concern, and I don't think you can get away from it. But the authors would argue that where there are several euploid embryos to choose from, prioritising the transfer of one over another, based solely upon non-genetic testing such as morphology, is a disservice to the long-term welfare of the future child. Suppose a couple has two euploid embryos, one of which has a higher chance of developing a serious neurodevelopmental disease than the other. The couple would almost certainly choose the embryo with the lowest risk of NDD. If the implantation fails, perhaps they will then transfer the other embryo, knowing that there is a higher risk of neurodevelopmental disorder, or they may elect to have another round of IVF, which may be considered elective rather than medical necessity, to lower the chance of having a child with a serious disadvantage or high risk of disease. So it may prompt people to have more IVF than they otherwise would, purely and simply chasing a highly selected form of the child that they need. So they concluded, I've almost finished this first part of the talk, PGT-P is a natural extension of genetic testing of embryos. Polygenic testing differs from PGT-A and PGT-M mainly in the complexity of the relevant science. So rather than condemning PGT-P with vague worries about playing God or the lack of equal access for everyone, which applies to most scientific breakthroughs, the authors argue that we should focus research on improving the predictive power of polygenic scores for all ethnic groups and on demanding that providers empirically validate their results. So this is alluding to the fact that all the different providers of polygenic testing have different sets of rules, different algorithms, different applications of AI, and they may therefore differ in how they rank embryos. And I think this is going to be one of the really critical things going forward. Can we actually trust the providers of the genetic score as to be actually true and accurate? And we've seen with PGT-A that is not this case. And they said we should also focus ethical and policy discussions on how to harness the promise of genomic prediction of embryos so that parents can make informed choices about their future children. I look at it saying, what I would have said was we need to contain the genie in the bottle before it escapes, to manage its progress rather than allow other agendas to exploit it. And I can guarantee if you let the genie out of the bottle, lots of companies will exploit it. And at the end of the day, some couples will be really happy with the child they have, but there'll be a lot of confused and angry couples not knowing actually what they've paid their money for. A bit like oocyte freezing. So what does the PGA data look like? Well, I found two. One is from a website and one is from a paper. The first one is from the Herocyte website, which you go to. It's just public domain. They've got a tool there, which I chose for breast cancer, and I chose a family diagnosis, mother diagnosed with breast cancer, 5 embryos, and produced some score, which I have to say I do not fully understand. I've contacted Herocyte, but they have yet to reply to me about what that specifically means. A far better way to understand it is to look at this illustration from a report, which I'll talk about in a minute. A couple has 4 embryos. All have been tested to be euploid, that is 46 chromosomes. Let me just put my glasses on. 2 are male and 2 are female. But what I think most people could understand this graph, that is the embryo 1 had a high risk of diabetes and a low risk of breast cancer. I should point out that this couple came on with a family history of diabetes. They've already had one child with class 1 diabetes, and there was a family history in the mother of breast cancer. But the second embryo had a high risk of diabetes, a really high risk of diabetes, but none of breast cancer. The third embryo also had a high risk of diabetes, but none of breast cancer. And the fourth had a moderate, well, they said normal, but it's 79% risk of developing type 1 diabetes and a small risk of breast cancer. So it depends where the couple's focus will be. They may say they don't want any of those embryos and just walk away. Or they might say, well, my main focus is not to have diabetes, so I'm not going to put embryos 2 and 3 back. I'll put back 2 and 4. They're both females, so therefore there's a small chance of breast cancer. So embryo number 4 will be the one of choice because it has a moderate risk of diabetes, a lower, but almost a very low risk of breast cancer. This may be the second embryo, and they may just choose to discard embryos 2 and 3. So that's kind of the way I think it will work. As I think we've already talked about this, I don't think I'm going to repeat it. You can go onto the website and do your own testing. But what I haven't found is that the explanation for it is sufficient for a layperson, because I didn't quite understand what these relative risks actually meant. But I want to come back to the paper published in 2000, pre-implantation testing for polygenic diseases, relative risk reduction. This actually is a good paper. It's open access, and it does 3 things. The first thing it does, as I've just explained, is look for a case where there's a known risk of type 1 diabetes in the family. They've already had a stillbirth and a child, and they don't want to have another child with class 1 diabetes. And so they will naturally come in and choose either none of the embryos, because they all have a risk, but choose this embryo number 4, which has the lowest risk. And how they manage that would have to be discussed both with clinicians, but this is where you need to have a genetic counsellor giving you advice. But even I, a mere male, can quite clearly decide that if it came in mainly to not have another child with class 1 diabetes, you would choose embryo number 4. It's a girl, it's a female, therefore there's a risk of breast cancer, but the risk is very low, only 10%, and that's probably worth the risk. But they also did something interesting. They also give you an idea of the relative likelihood of getting a risk. So the second part of their story was they chose 24 cases who were having PGT-A. So look, they were having IVF anyway. They're having embryos biopsied, but they consented to have their embryos tested genetically. And these couples had no serious risk of adult illness. And then they tested this whole range of different conditions. I won't go through them all: diabetes, cancers, metabolic diseases, etc. And there were the differences between Asian and Caucasian clients. Right? But the important one, none of them had any first-degree relatives that were affected with any of these polygenic diseases. So basically, if you like, a fairly random couple coming through for IVF. And this is what they found. Of the 181 tested embryos they tested, right, they found that a third of them, 67 out of 181, were aneuploidy. So already you've lost a third of those embryos. But that's what will happen anyway in IVF. But then they went back and looked at those embryos that were euploidy. How many of those had a high risk of a inheritable disease when there was no family history? And they found that none of 28 with no known history had a high genomic score, and none out of 3 with a more distant affected relative were affected. Among the Caucasians, 3 out of 51 embryos were identified at high risk from one of the genetic tests they had done, even if there was no family history reported. And 3 out of 28 if there was a more distant one. And importantly, with the case where there was a first-degree affected relative, all 4 embryos were affected. So this gives you an idea that if there's no family history of a major genetic risk, people will have a fair degree of confidence that most of the embryos they select will be both euploid and be available for transfer. So it's not really going to affect, you're not going to lose any embryos from it. So what can you summarise from that? Well, one can say that, what does this mean? Well, for me, One can easily do PGT-A and PGT together because it's the same sample. There's no extra biopsy. But we'll know that if you're coming in for PGT-P, about a third to a quarter of all the embryos, a third to a half, will not be suitable for transfer because they're aneuploidy or mosaic. And the likelihood of an embryo being at high risk for a couple with no known history is very, very low. Even for couples that have a very distant relative with some condition, the chance of an embryo being at high risk is also very low to moderate. It strikes me as a fairly attractive odds. And the last thing is, this is quite a complex table, and if you want to switch off and pause and go and make yourself a cup of coffee, that's fine. But what they did I thought was rather intriguing and gives you an idea of the power of using PGT-P to reduce the risk of transferring a condition where there is a high risk. And what they did was they went to the biobank in the UK and pulled out a whole lot of siblings, and they tested each of these siblings' DNA for a whole range of conditions: breast cancer, malignant melanomas, prostate cancer, testicular cancer, coronary disease, heart attack, hypercholesterol, hypertension, type 1 and type 2 diabetes. And then they chose one embryo which had the highest risk, let's say that's 100%. Then they looked at the likelihood of the sibling having what was their relative risk score for that particular disease. And in all cases, the second sibling had a reduced rate, I think, which by definition, because they chose someone was highest. But it was the degree of difference that I thought was important. So for some of the cancers, 15, 20% maybe reduction if you're choosing selection rather than just natural process take place. But for heart attack, look at this, 50%. If you had a sibling with a high relative risk for heart attack, and then you looked at the sibling with a lower risk, generally speaking, they had half the risk of their sibling. So if you're applying this to, not to humans as they've done here, to adults, but embryos, you may anticipate that if you apply a relative genetic score, risk score for heart attacks, just on, and you found some and found some others that are very low risk, you can guarantee in reducing in the child its child's chance of developing coronary disease by up to 50%. I don't think I said that very well. I apologise. Maybe you need to go back to the article and read it yourself. It's open access. But this data does show a clear benefit of some genetic selection if you only have one or two siblings of an unknown family history of disease. So they were testing adults, but instead of testing adults, they were testing embryos. And it gives you an idea of the power of the technology in predicting the relative reduction risk of a particular disease. And I think a lot of people may be quite drawn to this, quite an attractive option. So my thoughts. On the face of it, PGT-P seems a very attractive add-on, given that there is no additional risk to the embryo that has already been biopsied. It may allow other parameters to rank embryos in order for transfer rather than just morphology, but there will be a considerable cost and maybe some surprises in what risk may be identified in the couples themselves. So I can imagine a couple coming through and yes, Nick, we'll have our embryos tested. And then when the embryo data comes back, they show there's an increased risk of coronary disease or breast cancer, and the couples themselves don't know that because they haven't been tested. They haven't been testing their embryos. So there may be some feedback risk to the couples that they hadn't anticipated, which may have unintended consequences. There may also be some concerns about how the genomic index is being calculated. We've seen that in PGT-A, considerable variation in what testing units define as aneuploidy and as mosaic, leading to considerable variation in embryo wastage. My concern, look at how clinics can accommodate this technology. So, will it make busy clinics even busier? IVF clinics are already very, very busy. Adding a new class of clients that involve extended culture, biopsy, vitrification, prolonged storage, and new counselling may generate more revenue, but more burnout as well. Will there be a different class of clients? Most people attending for PGT-P will be fertile rather than infertile couples. They will attend because they have real anxiety about the health of their children, or couples just wanting the best future child. And I think this is the group, this is the canary in the coal mine. People, when they start thinking about saying, well, we want to have the very best child that we can, and we're going to use PGT-P to select that, creates a whole new class of counselling and patients. The next point I'm concerned about is counselling will all be about genetics rather than fertility. One main issue here is there are just not enough genetic counsellors at present, let alone for PGT counselling. But it will still require IVF counselling, especially with egg and embryo numbers and likelihood of success. And that's a lot of counselling people have to go through. And some people will be able to accommodate very easily, but I know many couples coming through, they just get swamped with the information. All they want is a baby, and they get confused by all the information being given out, often by doctors. And then the other thing that I'm concerned about is that it may generate a different class of embryos. Not only will embryos be euploid or mosaic, they will now carry a relative genetic risk where couples may elect to keep or discard embryos on quite different concepts to future adult illness. And everyone will be having their embryos transferred, stored or discarded, and it'll all be a relative thing, and it'll be very, very confusing for clinics to be able to manage that. I'm concerned that tanks will become full of normal but damaged embryos while people decide what to do. While this may be manageable, it sounds like a disaster waiting to happen, particularly if the wrong embryo is transferred and you produce a child that had the wrong relative risk to what the couple expected. And I think the potential litigation for this is actually enormous. The concepts of relative genetic risk, I have to say that even though I presented that table with the 4 embryos as being fairly straightforward, the concept of genetic index is a really difficult concept for lay people to process. And I sometimes wonder how anyone can be expected to rank their future child on the balance of potential future risk, where every embryo, if you screen for lots of different traits, you'll find every embryo has some relative risk. There'll never be a perfect embryo with no risk at all. And people may have difficulty processing that, knowing that their child might have a 10% risk of coronary disease when they didn't know they had coronary disease in the family, may produce a different interpretation on the value of that child. And therefore you get to a different class of expectations. It seems to me that clients will be investing future health of their children based on a genetic score that's not necessarily applicable to that couple. And maybe in the future the score would be different if applied with new data. I believe it exposes the clinic to potential future litigations if their expectations are not met. So, the final thoughts, you almost probably have another cup of coffee. Maybe there in the future, specialised AR clinics will just do PGT-P. So separate from genetic testing from infertility treatment. Maybe robotics in IVF will improve the efficacy of IVF to cope with the demand. But the initial robots, I've seen them, and it takes 10 times longer to use the robots than it does. And look, sorry, my wife was just going up. Okay. And lastly, maybe clinics' cryo storage will be able to cope with the demand, but I suspect they're already being inundated and flooded with oocytes being stored for fertility preservation, and adding a whole new class of embryos, which with some relative risk is going to be really difficult, and the computer systems will struggle to accommodate this. And the last concern is just the swampiness of it, the huge potential number of clients. There are far more couples with a genetic risk of breast cancer or prostate cancer or bowel cancer than there are infertile couples or women undertaking fertility preservation. Whilst the aspiration of the scientists wishing to pursue PGT is valid, I can see it having some value if there is a real risk of a child having, let's say, class 1 diabetes. When you already have a child with that, you don't wish to have another. But as soon as you start applying it to the general risk and future health of the child, it becomes a Pandora's box. PGT may make some companies very rich, but it runs the risk of swamping IVF clinics. Whoop, this has been a mistake. I apologise for that. Whoops. And clinics need to start forward planning on how they will approach or offer PGT-P. So I'd like to thank you if you persevered to the end. My name's James Danger. I'm an embryologist with 50 years experience. I'm not a medical person. And this information is not medical advice, but it may help you in knowing what questions to ask about your treatment with your doctor, and maybe to help in understanding the advice you receive. If you like what I'm doing, please press subscribe, make a comment, and press like. If you want to, you can go and give me some financial support to my GoFundMe page. And lastly, this is supported by another website that I run, FirdAid, which is an online EQA program for scientists in andrology and embryology. And if clinics subscribe to this, the important thing for clients is they know that the skills of the laboratory staff are under constant review and assessment and meet fairly good standards. We offer supports programs in andrology and embryology. But the good thing about my FirdAid site is you can act as a trainee as a professional, can use small or large clinics, and it can be used for training or competency or accreditation. Okay. I think we've had enough. I think you need that second cup of coffee. I'd like to thank you for perseverance. I reckon IVF is a personal journey that involves the actions of many technologies and people, and it helps to understand all aspects of that journey. I hope this information may be of value. If you like the information provided, please tell other clients about this service and please subscribe. Okay, I think I'll say goodbye.